Hello and welcome to the monthly Henry Schein series, Health Concerns in Dentistry, How to Ensure the Safest Dental Visit, featuring Dr. David Reznik. Hello, I'm Dr. Gary Severance with Henry Schein, and today Dr. Reznik is coming to us from Hawaii and taking time to address the continuing data on long COVID, acquired immunity, and the end of the public health emergency. Mahalo, Dr. Reznik.
Thank you, Dr. Severance, for the introduction into today's presentation. We're going to look at acquired immunity, something that was somewhat controversial early on in the pandemic. Is it real? Do we actually have it? And now the evidence is showing that we do have it. We're going to talk about long COVID and symptoms that people have when they come into your offices. They could have shortness of breath. They could tire out easier. How is that going to impact us when we know that 2 to 4 million Americans have not returned to work because of long COVID? And we're also going to talk about the end of the public health emergency and how that impacts our practices, how that impacts access to vaccination, boosters, and medications. So with that, let's get started with this month's webinar. So let's get started. Where are we with COVID by country? I'm sure you all are familiar with this map. Green means very minimal transmission. Yellow means it's a moderate level, and the orange areas are high. So if you look at the area, there's only a few parts of the country that are really seeing high levels. You can see moderate levels on Cape Cod and Massachusetts and New York. So there are places, even South Dakota, there are places where you have moderate levels of community transmission, and we need to be aware because that impacts maybe how we go about our daily business and things that we need to do to help our elders. That is another area that I'm going to talk about today, is how this is impacting our elders and steps that we can take to prevent more deaths. So if you look at the CDC data with COVID update, and you can see that the cases are going down, but we still had, last week, 260,000 cases. There were close to 3,000 deaths. That is a lot of people. New deaths, hospitalizations, 3,500. And then the vaccination rate with an updated booster is actually closer to 17 or 17.5. Excuse me. So the total deaths that we have seen are 1,113,000. That is just a lot of people. And so it's something that we still need to keep our eye on, look what's happening and where it is in our community. So how do death rates? And I want to talk a little bit about social media today, not a lot, but I want to talk a little bit about it. How do death rates from COVID-19 differ between people who are vaccinated and those who aren't? And really, we need to look to understand how this pandemic is evolving. And it's crucial to know how death rates are affected by vaccination status. Death rate is our key metric that can actually show us effective vaccines are against severe forms of the disease. So do the vaccines work? Are they beneficial? It is essential to look at death rates by vaccination status rather than the absolute number. And why? During a pandemic, you might see a headline that says, half of those who died from the virus were vaccinated. So if you were, and the way that comes across is, okay, if 10 people died, 5 of them were vaccinated and 5 of them were unvaccinated, what's the benefit of vaccination? And that's some of the things that we see play out on social media. But it's wrong to draw any conclusions about whether the vaccines are protecting people from the virus based on this headline. The headline is not providing enough information. So again, people take a little snippet and they get that snippet and they try to move it along. So let's look at this chart. This is a chart of 60 dots. Let's make this 60 people. And so we'll start off with this with nothing going on. Now we learned that 10 people died and 50% of them were vaccinated. So this is that headline that you would see. 50% of those people who died were vaccinated, and then we look at the 50% who were unvaccinated. So they'll take this chart and they'll move it along saying that, oh, it doesn't work. But the newspaper, like I said, half of those died from the virus were vaccinated, but it doesn't tell anything about if the vaccine is protecting people or not. To be able to say anything, we need to know about those who did not die, how many people in the population were vaccinated, and how many were not. So if you look at this chart, you can see that there were 10 that were unvaccinated, and of that, 50% died, and 5 of 50 who were vaccinated, so only 10% of those vaccinated had died. So although the death rate is 5 times lower amongst those that were unvaccinated. I said that right, that the death rate among vaccinated is 5 times lower than those who are unvaccinated, just checking. So this gives you an idea about how people will take a headline and move it for whatever their own benefit is. My point that I'm trying to make, I guess, is that we need to read the articles. We need to look inside and see really what's going on before we jump to conclusions, especially in this era of social media. So we look at the COVID-19 weekly death rate by vaccination for all ages. And looking back last year when we had a huge spike, January of 2022, what you can see is that the death rate for unvaccinated was 28 per 100,000 people, and those who were vaccinated without the bivalent booster was 2.79. So unvaccinated were much more likely to die compared to those who were vaccinated. And again, we're looking at source from CDC and their vaccine breakthrough status. If you look at a more recent date when it was low, December 3rd of 2022, it was 1.79 per 100 who were unvaccinated died. Those who were vaccinated without the bivalent booster was down to 0.35, and vaccinated with the bivalent booster, 0.16. So we're basically limiting the number of deaths we should see if people get vaccinated and stay up to date. I think that's one of the concerns that we have to address. A new CDC study showed that people who got the updated bivalent COVID-19 booster at the end of last year were 14 times less likely to die from the disease than people who were never vaccinated, and 3 times less likely to die from the disease than those who got only the original vaccine. The original vaccine is actually holding up pretty well, I will say that, but we need to look at our elders. Older adults saw the biggest boost in protection from the bivalent booster, and that's the group that we really need to work on when people are coming into our offices. The study also offered evidence that the bivalent booster's protection begins to wear after a couple months. So, but it does last, and we also have a certain amount of acquired immunity. So again, this is just a chart that shows what I was talking about. The updated COVID-19 vaccine does help save lives. 14 times less likely to die compared to those who received no vaccine, and 3 times less likely to die compared to those who received only the original vaccine. So we are seeing the impact of the vaccination status and how it's working for us. The CDC authorized this bivalent booster on September 1 of 2022. The bivalent booster is an updated version of the predecessor, which was a monovalent booster, and was designed to address the B4 and BA5 strains of COVID. The authors write that 17.5% of people aged 12 and older had received the bivalent booster at the time of publication, and this was 220. The Omicron strains were widely circulating during the study, now account for less than 1% of cases, according to the CDC. The current predominant strain is XBB.1.5, which we talked about last month, and there's some initial evidence that the bivalent booster offers protection from severe COVID or death during this era. So if you have someone who has a weakened immune system, or live with someone who does, or you're living with elders, you really need to have something put in place so you can be ready. Just like if you have an exposure in the dental setting and you get a needle stick, you're prepared, you have a standard operating procedure in order. If you have family, you have patients that have a weakened immune system or live with someone who does, or people who are elder, then there's a plan to do. So get the updated vaccine, improve ventilation, spend time outdoors when possible. Learn about testing locations and treatment options before getting sick. The medications work really well. Paxlovid is a 5-day medication. It does work. There have been some well-known people who have had rebound, but for the most part, we don't really see a lot of rebound. Get tested if you've been exposed or have symptoms. I'm out of the state right now. I'm in a different state, and they actually have an alert that if you've been around somebody who has been exposed, they will text you, which is actually pretty remarkable. Hand washing is the #1 thing to prevent healthcare-acquired infections. It also is one of the best ways to protect ourselves. And then for those who are severely immunocompromised wearing a respirator or a mask when you're in crowded spaces is important. And try to avoid crowded spaces, so spending time outside. So what about this SARS-CoV-2 infection protection against reinfection? And this is not based on someone's opinion. This is actually a systematic review and a meta-analysis. And I know it is somewhat controversial because people who were talking about acquired immunity were shut down. We had actually talked about it and thought that if you did have it and then you got your vaccine, that you would actually be super protected. That's what we did a few years back. So the authors identified a total of 65 studies from 19 different countries. Their meta-analysis showed that protection from past infection and any symptomatic disease was high for ancestral alpha, beta, and delta variants, but was substantially lower for the Omicron BA.1 variant. Pooled effectiveness against reinfection by the Omicron BA.1 variant was 45.3% and 44% against Omicron BA.1 symptomatic disease. Mean pooled effectiveness was greater than 78% against severe disease, which means hospitalization and death, including BA.1. So if you look at this, if you've been infected before, you do have some acquired immunity, and that's what's important. Protection from reinfection from ancestral strains like alpha and delta variants declined over time, but remained at 78.6% at 40 weeks. That is very, very significant. Protection against reinfection from the Omicron BA.1 variant declined more rapidly and was estimated to be 36.1 at 40 weeks, which is why it's important to get that booster. On the other hand, protection against severe disease remained high for all variants, with 90.2% for ancestral alpha and delta variants and 88.9% for Omicron BA.1 at 40 weeks. So there is protection if you've had this disease, but you really don't want to go out and get this disease because of long COVID. So looking again at this systematic review and the meta-analysis, the immunity conferred by past infection should be weighed alongside the protection from vaccination when assessing future disease burden from COVID-19, providing guidance on when individuals should be vaccinated and designing policies that mandate vaccination for workers or restrict access on the basis of immune status to settings where the risk of transmission is high, such as travel and high occupancy indoor settings. So that was basically finishing up that component of how do we look at acquired immunity and vaccination status and when should we merge them. But I do want to talk about long COVID because it disables millions of people and it looks like it's impacting the brain and the nervous system. And I think that, again, for us is important. People with long COVID have symptoms such as pain, extreme fatigue, and brain fog, or difficulty concentrating or remembering things. As of February of 2022, the syndrome was estimated to affect about 16 million adults in the United States and have forced between 2 and 4 million Americans out of the workforce, many of whom have yet to return. So we're talking about a disease that lasts. So yes, you can get natural immunity and you might not get reinfected, but those who have severe disease who end up in the hospital are more likely to end up with long COVID, which has all of these different symptoms associated with it. It often arises in otherwise healthy young people and even after a mild infection. So again, even though you can get natural immunity, one thing you do not want to get is long COVID. The risk appears to be slightly higher in people who are hospitalized for COVID, as I just mentioned, and in older adults who end up in the hospital more often. Women and those at socioeconomic disadvantage also face higher risk, as do people who smoke, people who are obese, or have any kind of array of health conditions, particularly autoimmune disease. Vaccination appears to reduce the danger, but does not entirely prevent long COVID. So it can reduce it from you getting infected, hopefully. We do know that you can get vaccinated and get the disease, but it'll be a milder version. So we do think that vaccination is somewhat helpful. The most common, persistent, and disabling symptoms of long COVID have to be with the neurological systems. Some are easily recognized, such as brain or nerve related. Many people experience cognitive dysfunction in the form of difficulty with memory, attention, sleep, and mood. Others may seem rooted more in the body than the brain, such as pain and post-exertional malaise, a kind of energy crash that people experience even after mild exercise. But those two result from nerve dysfunction, often the autonomic nervous system, which directs our bodies to breathe and digest food and generally runs our organs on autopilot. Again, this is not something that I want to have. This is not something people listening to this webinar are wanting to have. And it's definitely not something we want to bring to the older members of our family. The so-called dysautonomia can lead to dizziness, racing heart, high or low blood pressure, gut disturbances, sometimes leaving people unable to work or function. These patients are going to show up in our office for dental work. They might be tired, like I said, they might need more breaks, they might have memory concerns, but if we know and we document it, then we can manage these patients better. The SARS-CoV-2 virus is new, but post-viral syndromes are not. Research on other viruses and on neurological damage from the human immunodeficiency virus, HIV in particular, is guiding the work on long COVID, which is why I've been involved with COVID since the beginning, because working with HIV has been what I've done my entire career. Determining which patients have ongoing inflammation could help inform treatments. Early research identified markers that are often elevated in people with this condition. So eliminating any kind of inflammation from the oral cavity should have a positive impact on the systemic disease. The virus could linger in the brain for months, according to research conducted by the NIH and reported in the journal Nature in December of last year. The autopsy study of 44 people who died from COVID found rampant inflammation, mainly in the respiratory tract, but viral RNA was detected throughout the body, even in the brain, as long as 230 days after infection. Two other studies, both published last year in the Proceedings of the National Academy of Sciences, USA, showed evidence that SARS-CoV-2 may infect astrocytes, a type of neural support cell gaining entrance via neurons in the skin lining of the nose. Again, why we don't want to get this disease. The study, partly funded by the NIH and published in JAMA Network, looked at more than 800 adults who were treated for the virus between August 2020 and July 21. It found that at the 6-month mark, more than 70% of the participants reported continuing symptoms such as coughing, rapid or irregular heartbeat, and breathlessness. Do we have pulse ox in the dental office? Should we look and see what our saturation is for our patients prior to doing some extreme work, not just conscious sedation? Should we be taking blood pressures to see where our patients are? Should we ask them symptoms? Are you having a rapid heartbeat? Are you coughing and having continued symptoms since your infection? It might help guide us. But as I stated earlier, we have not changed at this point in the disease. We have not changed how we manage our patients. We still have the N95s on, the extraoral evacuation systems, all the HEPA filtration systems, all of those different things that we purchased at the beginning, we are still using. The air I have in my dental clinic is so much better than any place else that I go, even in a wonderful place like I'm at today. The study found that many COVID long haulers develop different healthcare challenges as time goes on. Higher rates of heart and lung problems 6 months after coming home from the hospital, highlighting that new symptoms can develop long after the initial infection. Many adults researchers found that more than half of patients experience financial challenges up to 6 months after being discharged, with Hispanic and Black participants most likely to be affected. Among this group, about 30% said their family finance were moderately severe or extremely drained as a result of the hospitalization. Again, we've heard about these being on Medicare, having these kinds of diseases, and the strain it is on retirement accounts. It's very important. So let's look about this on the research side. Severe fatigue and persistent symptoms at 3 months finding SARS-CoV-2 from pre-Delta, Delta, and Omicron time methods, a multi-center or MAC prospective cohort study. Most research on SARS-CoV-2 variants focus on the initial symptomatology with limited data on longer-term sequelae. The authors looked to characterize the prevalence and differences in prolonged symptoms at 3 months post-SARS-CoV-2 infection across the 3 major variant time periods, pre-Delta, Delta, and Omicron. Look at this research, the multi-center prospective cohort study of adults with acute illness tested for SARS-CoV-2 compared Fatigue severity, fatigue symptoms, individual and organ symptom-based symptoms in the presence of greater than equal to 3 total symptoms across variants amongst COVID positive and COVID negative participants 3 months after their diagnosis. The study included 3,223 participants, 2,402 COVID positive, and 821 COVID negative. Amongst the COVID positive cohort, about 19.3% were pre-Delta, about 49.9% or about 50% were during Delta, and about 30.8% during Omicron. Prolonged severe fatigue was highest in the pre-Delta COVID positive cohort, the one where we're talking about respirators and the shortage in our emergency rooms were overwhelmed, compared with the Delta and Omicron cohorts at 16.7 versus 11.5 versus 12.3 respectively, as was the presence of 3 or more prolonged symptoms, which was 28.4 versus 21.7 versus 16, so it was significant. The whole key is that people are showing these kinds of symptoms well after the infection. Prolonged symptoms following SARS-CoV-2 infection were more common among participants infected during the pre-COVID period, pre-Delta period, compared with Delta and Omicron. However, these differences were no longer significant after adjusting for vaccination status. This suggests a potential benefit effect of vaccination on the risk of developing long-term symptoms. Again, this is another reason to stay up with vaccination because it might help reducing these long-term sequelae. And yes, it's not as much now as it was in pre-Delta. We are in Omicron. We're seeing less deaths, but still too many deaths. But again, vaccination and following some common sense guidelines are what's going to get us out of this disease. This is really something that is beginning to bother me. Seniors seem to have been left behind as we go back to normal in COVID-19. Older adults have the highest COVID vaccine, but their booster uptake is also low. As of mid-January, about 39% of Americans 65 and older had received the bivalent booster versus 94% uptake at that age for the 2 initial vaccine doses. So there is some people who are going out and getting it, close to 40%. Evidence shows that the booster shots makes a significant difference. In November 22, according to the CDC, the COVID-19 hospitalization rate for unvaccinated adults aged 65 and older was more than 13 times higher for their peers who had received the bivalent booster. The rate was 2.5 times higher for older adults who only received the 2 primary vaccine doses. So getting the primary vaccine doses does help, but getting the booster helps even more. COVID-19 deaths in the US are a fraction of what they were at the beginning of the pandemic, but older adults, our families, our parents, our aunts and uncles continue to bear the brunt, making up nearly all the COVID-19 fatalities that still occur every day across our nation. In the first week and a half of 2023, 1,129 COVID-19 deaths were reported to the CDC. All but 17 of these deaths were people ages 50 and older, and almost 3/4 of people were 75 and older. I don't know about people listening, but to me, my older family, who has the history of our family, who knows things that I don't know, they're so important to keep into our lives and so important to keep healthy that I think it's our duty to take care of the elderly. That's why I'm a big proponent of Medicare covering oral health, because then we can reduce inflammation, have better outcomes and longer lives for those that we love. Of the more than 1 million COVID-19 deaths in the US since the novel coronavirus arrived, about 3/4 have been among people 65 or older. I will say I have a birthday coming up in a few months where I hit that mark. So I'm going to make sure that I take good care of myself. This is also new. In a first, the COVID-19 vaccine is added to the adult immunization schedule. COVID-19 vaccines have been added to the list of routine immunizations recommendations for adults. A further sign the virus is endemic. It's here to stay. In other words, as we would hope that this would come and go, after 3 years, we know it's still here. It's probably not going anywhere. We have other viruses that we'll talk about in the future, such as the bird flu, which is beginning to transform to go from birds into mammals. And we have to keep a close eye on that because that was a scare we had before. But right now, we're still dealing with COVID. And the addition of this in the 2023 recommendation adult immunization schedule by the Advisory Committee on Immunization Practice, ACIP, an expert panel that advises the U.S. federal government on vaccination recommendations for Americans. This reiterates that COVID has gone from pandemic to endemic, meaning that disease is spreading at a more stable frequency versus the exponential growth we saw when we were shut down. The CDC recommends one dose of the updated booster for everyone ages 5 and older, if they are at least 2 months since their last dose out. Right now, I am focusing on adults. I am focusing on adults, no matter what their age is, and especially if they're 50 and older. Key updates to the schedule were published in the CDC's MMWR include the addition of COVID-19 primary vaccine series and a recommendation on booster dose vaccines, updated guidance on influenza and pneumococcal vaccines, and new vaccines for measles, mumps, and rubella, and for hepatitis B. Hepatitis B is another disease state that we will cover as we move on, but most of us have been immunized against hepatitis B. The key is when you get to be my age is to check and make sure what your titer levels are. Are you still protected? I did that about 5 years ago, and I just did that again just to check. And yes, I am still immune to hepatitis B. I'm still immune to hepatitis A. I had overseas travel. They recommended that I get the hepatitis A vaccine, so I went through that. At my age, I've had the pneumococcal vaccine. I've had the shingles vaccine. I mean, we really need to talk about things that we can do to help our patients. And one of the most important is the HPV vaccination. Human papillomavirus is the most commonly transmitted virus that there is, and sexually transmitted virus that there is, and we can immunize against it, and it's the #1 cause of head and neck cancer in the US. So looking at what kind of advice we can give and things of that nature will be part of our series as we move on into healthcare issues impacting dentistry. The public health emergency is getting ready to end, and what does that actually mean? And so I thought we would go over some of it. It does start on May 11th of 2023. Amongst the most significant effects of ending the emergencies are that many Americans could have to start paying for coronavirus testing and treatments depending on their insurance coverage and where they live. Moderna, which got some really bad press when they said that they were going to charge $110 to $130 per dose, has decided they're just going to not ask Americans to pay since our taxpayer dollars had funded most of their research. And I think that is good. For those who are afraid of the mRNA vaccine, and I know there's all this information on different sources of social media, there is an old-fashioned type flu vaccine. It's not flu, but it's for COVID-19, made by a company called Novavax. So it doesn't involve mRNA. It's a more traditional vaccine. It is available for the primary and secondary shots. So your first two, it has not yet been approved as a booster. Are they working on it? Yes. So if you want to avoid mRNA, if that's what your concern is, there is an option. And I think that's important for people to realize as well. It is also important to note that the administration's response is not fully dependent on the public health emergency. There are flexibilities and actions that will not be affected as transition from the current phase of our response. As described below, the administration is committed to ensuring COVID-19 vaccines and treatments will be widely accessible to all who need them. There will also be continued access to pathways for emergency use authorizations. That's how we got our first vaccines approved. That's how we got our first medications improved, like Paxlovid. Very important that if you start to have symptoms and you test positive, get on that medication as soon as possible because it will reduce symptoms and shorten the course of disease. Also, major telehealth flexibilities will continue to exist for those participating in Medicare or Medicaid. One of the things that will greatly impact us is whether or not we can still give vaccines. Access to COVID-19 vaccinations and certain treatments such as Paxlovid and the other drug will generally not be affected. To help communities safe from COVID-19, HHS remains committed to maximizing continued access for COVID-19 vaccines and treatments. Vaccines recommended by ACIP are preventive health services for most private insurance plans and will be fully covered without a copay. Currently, COVID-19 vaccinations are covered under Medicare Part B without cost sharing, and this will continue. Medicaid will continue to cover COVID-19 vaccines without a copay or cost sharing through September 30th, 2024, and will cover all of the ACIP recommendations, recommended vaccines for most beneficiaries thereafter. So the key is we'll keep our eye on it. We have a year and a half or so to go, but Medicaid is covering this, Medicare is covering this, and insurance will cover this as well. It's the uninsured who don't qualify for Medicaid and Medicare, and there are plans in place to make sure they can get the vaccine and treatment if needed. Major Medicare telehealth flexibilities will not be affected. The vast majority of Medicare telehealth flexibilities that Americans, particularly those in rural areas who have difficulty with access, who struggle to find access, have come to rely upon the past 2 years, will remain in place through December 2024 due to the bipartisan Consolidated Appropriations Act 2023 passed by Congress last December. Medicaid telehealth flexibilities will also not be affected. States already have significant flexibility with respect to covering and paying for Medicaid services distributed or delivered via telehealth. Coverage for COVID-19 testing for Americans will test. Medicare beneficiaries who are enrolled in Part B will continue to have coverage without cost sharing for lab-conducted COVID-19 tests when ordered by a provider, but their current access to free over-the-counter tests will end, consistent with the statute on Medicare payment for over-the-counter tests set by Congress. The requirement for private insurance companies to cover COVID-19 tests without cost sharing, both for over-the-counter and laboratory tests, will end. Certain FDA COVID-19 related guidance documents for industry that affect clinical practice and supply chains will end or be temporarily extended. And please understand, we are not over the supply chain issues. We have gotten past the main concerns we had with supply chain, but there are going to be supply chain issues that might affect your PPE, that might affect, just like if, say you're in the electric car market and you can't get your car because we don't have batteries, part of that is a supply chain concern. You might have to change the kind of N95s that you're using. Remember, if you change brands, you have to get fit tested for the new brand. But we are going to continue to have supply chain concerns for a while, and they are going to impact dentistry. The ability of healthcare providers to safely dispense controlled substances via telemedicine without an in-person interaction is affected. However, there will be rulemaking that will propose to extend these flexibilities. During the public health emergency, the DEA and HHS adopted policies to allow DEA-registered practitioners to prescribe controlled substances to patients without an in-person interaction. So in other words, you haven't seen the patient from our perspective. You know it's a patient of record. You know that their treatment plan for a root canal, they missed their appointment. Can you call them something to get them in over until you see them the next time? The answer is yes at the present time. So once again, I want to thank you for your time and attendance. I think we covered a lot here today, but we're going to start looking at other symptoms and diseases that impact our practices as we move forward. As always, I look forward to your comments and suggestions on how we can improve this. And I'm going to turn it back to the wonderful Dr. Gary Severin. Thank you.
Thank you, Dr. Reznik, for the timely update. And thank you for watching. Please subscribe to our YouTube channel by clicking the subscribe button below. And to be notified of any premieres, click the bell icon. If you have any questions, concerns, or content you'd like us to address, please email us at webinars@henryschein.com. Thank you again for your attendance. Please stay safe and stay informed. Until next time.